Start. All right. My status people, we're going to start. All right. We're going to start. So I don't know if I'm supposed to sit in front of the camera or what. So welcome to our SIG on the vascular manifestations of systemic sclerosis, also known as scleroderma. And I know we have people online. We have a lot of our group. I'm going to introduce our group in a moment who actually weren't able to come. So I'm going to go ahead and start. Just to make sure everyone is on the same page. Systemic sclerosis is another name for scleroderma. Scleroderma means hard skin, but systemic sclerosis is another name, just to confuse everybody. And so we abbreviate it SSC. Raynaud's phenomenon, which we'll describe in a second, is what we're studying. That we abbreviate as RP, and digital ulcers are digital ulcers on your fingers. We'll describe those, and we call those DUs. This is what we're going to talk about today. I'm going to give a brief intro to what we're doing. Dr. Herrick is going to give a brief overview of vascular disease and scleroderma. Dr. Christopher Stein is going to also do something because she's preparing apparently. But we're going to hear from Edith Brown, our wonderful patient, one of our wonderful patient research partners, about her experience with these problems, unfortunately. We're going to hear about the qualitative research we've done, Dr. John Pauling. We're going to hear about our scoping reviews from Nancy Maltese, but unfortunately, Mike Hughes is not well, not able to join us. And then we're going to have a discussion on the work we've done up till then. Dr. Proudman's going to talk to us about the Delphi work that we've completed, which is leading, we'll discuss. And then I'm going to show you our draft course set for domains, because we've actually made it all the way to the course set. And we've actually did this surprisingly according to all the rules of OMERACT. Not sure how that all happened, but so that's where we're at. This is our group. Obviously, a lot of the names are already the same. I didn't get to, we've had two wonderful OMERACT fellows. We had a bunch of co-chairs from different continents. We have Edith, one of our patient partners, and Ms. Virginia Hickey, who I hope is on. Is she on? Okay, she's one of our other terrific, and we have this group, and then Dr. Park from NIAMS is on, National Institute of Arthritis, Musculoskeletal, and Skin Diseases from the National Institutes of Health, has joined us from the very beginning. And Bev Shea, who was drafted to another place, and Peter Tugwell. But the most important name is not on there because you might have yelled at me if I did, which is Shauna, who has kept us going and has been the rock to help make it all happen. I would say this group has been intact from the very beginning of the project, which is kind of interesting. And it has been very cohesive. So it's been a wonderful group. So what are we studying? Well, we've done our qualitative research on how these two manifestations, which are somewhat linked in scleroderma, impacts our patients. And we've done a scoping review of domains addressed in randomized controlled trials of Raynaud's phenomenon and digital ulcers. And there have been a number of randomized trials for each of these problems. And we've generated candidate domains and subdomains, which we then put into a Delphi exercise with patients and other stakeholders that we've included. And we're going to draft and finalize the OMERACT course set. We have really done almost everything, and but we're interested in feedback about how we've done it. We're close to finishing the domains you'll see today. So now I'm going to turn it over to Dr. Ariane Herrick from the UK, who wasn't able to come, but she's going to give you a brief description of the clinical problem. Ariane?
Thank you very much. Yes, I'm just going to give a very brief outline for those of you who might be a little bit less familiar with vascular disease and scleroderma. Peter, will you move the slides on, or can I move them on? Okay. That next slide. So most of you will know that systemic sclerosis is a multi-system connective tissue disease with various manifestations shown here, but we're focusing today on the digital vasculopathy, and that means a spectrum of disease, Raynaud's phenomenon, digital ulceration already mentioned, also critical ischemia, which I shan't mention further, which is a rare but important clinical part of the spectrum. Next slide, please. Many of you will know that Raynaud's phenomenon is color change of the fingers on cold exposure or emotional stress. And classically, the fingers change to white, and then blue, and then red. And next slide, please. And the red phase is often painful. Some patients progress to digital ulcers, shown here. On the right, you see a fingertip ulcer, and on the left, ulcer over the extensor aspect of the fingers, which occurs especially when patients have contractures, as shown here. And just how common is this? Well, Raynaud's phenomenon is very common. Virtually everyone with systemic sclerosis has Raynaud's phenomenon. It can be very severe. And about 50% of patients develop digital ulcers. So again, very common. And many studies have shown that. Next slide. The disease burden is enormous. Raynaud's phenomenon in a survey of almost 2,000 patients was said, as you can show in the histogram here, the organ complication perceived as having the greatest impact on quality of life on a day-to-day basis. And it's well known from a number of different studies and from patients telling us that digital ulceration is associated with pain, impairment of hand function, and work disability. So very major problems to patients. Next slide, please. So we need outcome measures. They're very important because we need them in clinical practice so that the clinician and the clinic can assess whether Raynaud's phenomenon in digital ulcers is or are improving, stable or progressing. And in research practice, we need outcome measures because we are very much in need of objective, reliable and feasible outcome measures to facilitate clinical trials. Next slide. I'm not going to talk in any depth about treatment of Raynaud's phenomenon and of digital ulcers, but I just wanted to show that the two are very much interrelated. At the top of the flow chart and on the left, you see a flow chart for treatment of Raynaud's phenomenon, which includes lifestyle measures and a variety of different drug treatments. And if despite these measures, Raynaud's progresses to digital ulceration, then next slide, we go to the bottom half of the flow chart, and there are a variety of different treatments for digital ulcers, including drug treatments, but a variety of other treatments, for example, surgical debridement. Next slide. But what actually is the evidence underpinning the drug treatment, which is necessary in most patients with systemic sclerosis for Raynaud's phenomenon for digital ulceration? Well, it's very weak. And this is showing results of a meta-analysis of treatment for secondary Raynaud's phenomenon. And in fact, calcium channel blockers and phosphodiesterase inhibitors, which are the first-line treatment generally for digital vasculopathy, are both superior to placebo, but only minimally effective. And all the other drugs that have been advocated for Raynaud's phenomenon really haven't been shown to have any good evidence base. So this emphasizes the need for further clinical trials. So the challenges are, next slide, please, to develop promising outcome measures for use in clinical trials and to deliver phase 2 and phase 3 studies. Next slide, please. And so in conclusion, systemic sclerosis-related Raynaud's phenomenon is often severe. It often progresses to digital ulceration, huge impact on quality of life. Current treatments are only partially effective, if at all, with a very weak evidence base, and we do need new outcome measures to facilitate clinical trials of promising new treatments. Thanks very much.
Thank you. That's a great intro. I just want to remind us that I can't think of a physical manifestation that we see as dramatically that is entirely patient-reported in rheumatology as much as Raynaud's phenomenon. Fatigue and pain are patient-reported, but we can't see it as much. But Raynaud's you see, and it's essentially entirely based on the patient's report. And so, which makes it its own unique challenge. Ms. Edith Brown, as I said, is our patient research, one of our two great patient research partners. I wanted to emphasize that she's a patient, but she's totally a research partner from the very beginning and has really been, just part of the team. It's been great. So, Ms. Brown, I know you're only representing the entire population of the world of patients with scleroderma, but no pressure. So tell us what you want to say.
Hello, everyone. My name is Edith Brown, and I'm from the north of England. And this afternoon, I'm Exhibit A. I am a scleroderma patient. Before I developed scleroderma, I was very active and sporty. I enjoyed hiking and cycling and sailing and skiing. In fact, I spent most of my leisure time being very cold and very wet. Because I live in the north of England, that's quite easy to do. Then things changed, and things changed very rapidly. I started to develop Raynaud's. I'd never heard of it before. I'd never heard of scleroderma before. But over the next few months, my hands turned blue, and they stayed blue for most of the day. I couldn't do anything about it. Even the slight change in temperature, even going into the fridge for a pint of milk, my hands would develop Raynaud's, and the Raynaud's would stay for many hours. It was very painful, very distressing. No matter how many layers of clothes I wore, my Raynaud's would still persist. Then along came the digital ulcers. They were the most excruciating things I've ever experienced. And sometimes they got infected and sometimes they persisted for many weeks. And I was advised to keep everything covered up with dry dressings, which has an enormous impact on your life. The impact on my daily life of having Raynaud's and digital ulcers was quite enormous. I went from being a very active outdoor person to somebody who could hardly do everyday things. The impact on normal everyday things that we all take for granted, such as washing your hair, chopping vegetables, making a meal, looking after children, it's practically impossible to do when you've got dressings on your fingers and your fingers are painful and your Raynaud's keeps persisting. Managing medication I found very, very difficult, particularly trying to pop little tiny pills from a tinfoil container. The impact on my career, I think, was very, very dramatic. I was a head teacher in a large comprehensive school and I loved my job and I had no intention of giving it up. But I was mindful of the fact that some people with scleroderma have jobs like catering or medicine or dentistry or physiotherapy or hairdressing. And those sort of jobs just cannot be done with scleroderma and vascular aspects such as Raynaud's and digital ulcers. So for those people and for an awful lot of people with scleroderma, the only option is to give up work, which is quite traumatic. Okay, that's a little bit about my background.
Thank you. So I think that speaks better than anything we can say about what we need to do. John Pauling is with us from the UK as well, and he's going to give us insights into qualitative research. His group has done an enormous amount of work on trying to understand patients' perceptions and reality with these vascular complications. John?
Well, thank you, Peter, for the introduction and also for the leadership you've shown to this group. You've really helped kind of move things along. And thank you to Edith there, because whilst we've learned a lot and gained a huge amount of insight from the patient experience of scleroderma, Raynaud's and digital ulcers, to hear Edith describe the impact it's had on her life really reminds us why we're doing this and how important the work is. If you can proceed to the next slide. So this is a quote I found from a paper from a few years ago. And I think even this quote was quoting previous work that really distinguishes quantitative from qualitative research by saying that quantitative research gives us knowledge, whereas qualitative research gives us understanding. And it was really understanding that we were seeking in the work we did to understand the patient experience of both scleroderma Raynaud's and scleroderma digital ulceration. Next slide. So we started, or the initial tranche of work we did really focused on scleroderma Raynaud's. We undertook 6 or 7 focus groups in 3 cities across 2 continents. We wanted to get the experience of patients who live somewhere really cold. So we did work with Robin Domsich in Pittsburgh. Somewhere really hot, so we worked with Leslie Ann Sackett-Koo in New Orleans, and somewhere where it rained all year round, so we did some work at our own institution. And this was the purpose of sampling framework we adopted for the Raynaud's work. So we wanted to make sure we got patients with early disease and established disease. We wanted to make sure that the gender mix was representative of our scleroderma population generally, but that we still sought the opinion of males who are, scleroderma is generally a lot rarer in males than females. And one of the rationales for undertaking work in New Orleans was to broaden our ethnic mix to ensure that we weren't just seeking the opinions of a predominantly white population. So we were able to get a representation from a large number of Black patients who are under Leslie Ann Sackett-Koo's care in New Orleans. And digital ulcers, as Peter and Ariane have described, affect about half of patients with scleroderma. And so we wanted that to be represented in our sampling framework as well. If you move on to the next slide. So the focus groups underwent thematic analysis, as is typical for this type of qualitative research. I think one of the major strengths of this particular study and the digital ulcer work was that it was undertaken by experienced qualitative researchers. This work was led by Sarah Hewlett, who many of you will know through her close association with John Kerwin and OMERACT. And by her own admission, she didn't come to this work with a good or thorough understanding of Raynaud's phenomenon, having spent much of her career working on inflammatory arthritis. So she was agnostic and didn't bring with her own biases and prejudices in terms of what she felt Scleroderma Raynaud's represented. And this was the kind of thematic map that she helped us with our patient research partners who participated in the study, separate to the patients who are involved, to make up a schematic for the patient experience of Scleroderma Raynaud's. So you can see at the heart of this schematic are the physical symptoms of Raynaud's, and these include pain, numbness, hypersensitivity, difficulty using their hands, the digital color changes we've heard about, and also feeling cold. And Raynaud's attacks, really, the reason there's a Venn diagram for those symptoms was patients definitely told us that there are these acute exacerbations of their Raynaud's symptoms in response to cold or emotional stress, leading to these typical attacks, which clinicians have certainly focused on a great deal in the past. But a lot of these symptoms exist when patients aren't necessarily in the midst of what we might consider an attack. So patients with scleroderma will experience coldness of their fingers, pain, some numbness, difficulty using their hands, even if the fingers don't have the well-demarcated color changes that might be used to classify or categorize a Raynaud's attack. These physical symptoms have an enormous emotional impact. We learned from patients about the impact Raynaud's has on ranging from upset and frustration with the inability to undertake normal tasks. We heard that from Edith. Also the embarrassment of their fingers changing colors and people drawing attention to this, and concern for the future. There were the triggers and exacerbating factors I've already mentioned. Cold is really by far the biggest one, but also emotional stress. The constant vigilance that patients need to adopt to help manage their symptoms. So I think when it comes to Raynaud's attacks, we need to remind ourselves that patients aren't innocent bystanders to the occurrence of these attacks. They take very active steps to prevent attacks. The active steps they're taking impact on their social participation. And then they take steps to ameliorate attacks when they're occurring. So they'll use hand warmers or put their hands in warm basins of water. And this really forms part of the adaptation that occurs over time. But all of this, including the adaptive measures patients take, has a huge impact on daily life and quality of life. And also, I've mentioned already the uncertainty that active Raynaud's symptoms creates in patients about what that might mean for their disease generally and its future progression. If we can move to the next slide, Peter. So we adopted, having published the work in Scleroderma Raynaud's, we decided to undertake additional work looking at the patient experience of scleroderma digital ulceration. This work was a UK-based study, and that was in part because whereas we felt it was very important to have broad geographic representation in Raynaud's because of differences in environmental temperatures, there was a general feeling, and this was supported with conversations we had with patients from elsewhere in the world, that the experiences of digital ulcers were similar irrespective of where people lived. So we recruited patients in Bath, Manchester, and London. Again, we adopted a deliberate purpose of sampling framework to make sure that we recruited a diverse population of patients with a broad range of different experiences of digital ulcers. And this included the number of ulcers they'd had in the past, ethnic mix, and disease duration. Next slide, please. So in terms of the patient experience of digital ulcers, this is the schematic map. There are clear parallels here between the experiences we identified from this work and the work from the Raynaud's, although the analysis was actually undertaken by a different experienced qualitative research team at the University of Bristol. Again, physical symptoms and signs form the mainstay of the experiences. This has a big psychological and impact and an emotional burden, fear, anxiety, embarrassment. There's a huge functional impact. We heard from Edith about the difficulty people have using their fingers when there are active lesions on the fingers. And then there's the mitigating factors that patients adopt to try and improve their symptoms and promote healing of their ulcers. And then there are aggravating factors around avoiding micro traumas that can set off ulcers, avoiding trauma when people have active ulcers, the fact that some patients will have more than one ulcer and then the impact that can have on their ability to use their hands. Thanks. And actually, we undertook a number of different analyses looking at not just the broader patient experience of digital ulcers, but also the nature of pain in digital ulcer disease, and the patient experience of how these digital ulcers develop and evolve over time. We wanted to understand that healing process and how the symptoms evolved during that process. So we learned a huge amount of insight from this work, and I'll be glad to answer any questions later on in the meeting.
All right, thanks. That was terrific. I think this was, we had a tremendous head start by having this qualitative research going into this. It was extremely helpful, and our patient says these really resonate with them. So we're going to now hear, we're going to take a little time to discuss insights from the scoping reviews that we did for both Raynaud's phenomenon and digital ulcers. This was led by Nancy and Mike, and Nancy's going to speak for both. These were done in parallel in very similar manner, but they really are. One of the interesting things we have discussed throughout our process is to what extent are these the same, do we study these in the same way or not? And that's something to think about as we go forward. Everybody with the digital ulcers has Raynaud's. Not everybody with Raynaud's has digital ulcers, but they're being treated by the same people and they're in the same set of hands. So what does that mean for us? So Nancy, take over.
Thank you, Dr. Merkel. I've been lucky enough to be one of the fellows on this great working group. So I'm just going to take a few minutes to summarize some of the results of our, like Dr. Merkel said, parallel scoping reviews. Next. So the primary objective of this study was to evaluate the outcome domain studied in clinical studies of systemic sclerosis-related Raynaud's. Next. We had a broad search strategy that was applied to MBase, Medline, and Cochrane Central Register, which are typical databases. These were used to identify studies pertaining to adult participants with systemic sclerosis-related Raynaud's. We didn't use any limitations in terms of intervention, comparator, or study setting. In terms of data collection, 2 reviewers collected the study characteristics and all the primary and secondary target domains. Next. So we identified over 6,400 records, and then about 4,800 were screened at the abstract and title level, 146 full text, and then 58 studies were deemed eligible for inclusion in the final synthesis. The studies were conducted between 1982 and 2019. 58 studies were included, like I said. 24 of these were RCTs, of which 19 were placebo-controlled. The intervention spanned intravenous drug therapies, oral therapies, and topical or injectable treatments. Next. So this scoping, the review identified outcome domains that were captured in terms of studying systemic sclerosis RP specifically. The results were synthesized and we summarized them into 3 overarching domains. These included clinical features and severity, impact on function and quality of life, and then special tests. And next. The majority of studies assess the severity of attacks of Raynaud's. The frequency of attacks and duration of attacks as determined by the participants were measured in 28 and 19 studies respectively. Pain was evaluated in 9 studies and physician global assessment of Raynaud's was gauged in 5 studies. Only a minority of studies assessed other patient experiences, including numbness, cold sensitivity, and patient global assessment, tingling, and color changes. Objective measures of digital perfusion were assessed in 44 of the 58 studies, and serum biomarkers were assessed in 6 studies. Interestingly, the impact of RP on function was measured in only 11 studies, and health-related quality of life was assessed in only 1 of the included studies. Next. So in summary, this scoping review really highlighted the broad spectrum of relevant domains in the study of systemic sclerosis related Raynaud's and helped to inform the next steps in achieving consensus. If we just go to the next one, we can chat about the scoping review that was run parallel, looking at the domains used for digital ulcers. So next, the primary objective was similar, but in this case, we were looking at outcome domain studies in looking at digital ulcers specifically. The methods were very similar. A very similar broad search strategy was used in the same databases, and inclusion criteria were also similar. We collected the same data pertaining to study characteristics and primary and secondary target domains. We screened over 3,700 abstracts and titles, and then 123 full texts, and then finally 40 studies were included in the final synthesis. Next. Sorry, next slide, Dr.
It's only 10,000 papers between two. Back, Nancy?
Yeah, it was easy peasy. We then synthesized similarly to what we did with the Raynaud's data into 3 broad domains. For digital ulcers, these included the burden of digital ulcers, the impact of digital ulcers, and special tests. Next. In terms of burden of digital ulcers, most commonly the digital ulcer count or number of ulcers was reported. We also had data pertaining to digital ulcer improvement and complications, and then global digital ulcer assessment. The impact of digital ulcers pertain to target domains, including function, pain, and less commonly health-related quality of life. Special tests were similar to those that we identified in the Raynaud's review in terms of objective measures of microvasculature, and there were also some histopathologic studies in the digital ulcer review. So I think overall, this highlighted, again, the broad spectrum of relevant domains in the study of DUs. I think what was also important pertaining to our working group is that there was a lot of overlap in terms of similarity in the domains, and that was very helpful for us to learn before moving forward and achieving consensus.
Great. So I think we First of all, thank you, Nancy. That was great. And Mike, I almost about to be accepted. It was a little delay in getting that revision. We hope to publish them simultaneously. So it's been great. So we thought we'd stop and take any questions or discussions for the work done to date. Yes. Oh, wait, you got your microphone. Microphone. Introduce yourself. Tell us who you are.
I'm Lara. I'm the fellow in the foot and ankle group, and well done on a fantastic amount of work. I wondered if you considered Raynaud's and digital ulcers in the toes at all, and if not, why not?
Anyone can answer that from our group?
I don't mind pitching in. The vast majority of so you're absolutely right. Raynaud's affects all the extremities, so the toes, the nose, the earlobes, the areolar tissues. Most of the published work in the scoping reviews has focused on the fingers. So there was some restriction in terms of the work in the literature that really focused mainly on the fingers, although I don't doubt some of those studies might have included the toes. When it came to the qualitative research, digital ulceration on the toes really is slightly different in its pathophysiology, we think. So that we think when patients with scleroderma develop digital ulcers on their toes, there's perhaps other aspects involved in the care, although the actual manifestations are very similar. We certainly didn't restrict the discussion to just the fingers, although most of the discussion did focus on the fingers, which is the main site of the microangiopathic digital ulcers in scleroderma. Again, in terms of Raynaud's, we were very open with our topic guide that we didn't specify. We allowed patients to draw on their own experiences. So we'd ask very open questions like, what does Raynaud's phenomenon mean to you? And then allow patients to speak. And what we found was generally the discussion did focus mainly on the fingers rather than the toes. And I think one of the reasons for that is our toes benefit from being well insulated in socks and shoes the majority of the time, although patients did talk about their toes occasionally. I don't think there were anyone in the group who only had symptoms on their toes and not their fingers.
Yeah,
I wonder whether
Edith
might want to comment further as well on that particular issue.
Yeah, certainly my Raynaud's mostly affected my fingers, but also my toes, particularly in the summer, and particularly in a time in the summer when you think you're going to be nice and warm all day. You walk into a supermarket and suddenly you're in a much colder environment and your hands and your feet can get cold.
I would add that it is rare for patients to mostly talk about their feet. I think the other thing is we're trying to develop outcomes for clinical trials, and it's hard enough to do clinical trials in Raynaud's, the fingers, but bringing in, I think this is a good example of sometimes practicality comes into place. If you try to capture the entire spectrum of disease, you'll never be able to study that disease. And so, but it's a good point. Perhaps it should be a footnote in our work. But
Peter, can I can I just make one response to that? And it doesn't need to carry on the conversation, but one of the things that we found, sorry, my name's Heidi Siddle, I'm chair of the foot and ankle group, is that people don't often get asked about their feet, and therefore they don't often get the opportunity to talk about it. And we've certainly found that even, in rheumatoid arthritis, where we know foot problems are really prevalent. So I think one of the things going forward would be in a qualitative review like that, and it would be to ask about the feet, because patients often think that because their feet are enclosed in their socks and shoes, that and clinicians don't often have time to look at them or to ask about them, because the hands are very evident, and they often gain enough information about the hands but not to purely understand the impact it has on feet. So we are doing a qualitative review, and we are for all foot and ankle, but we're focusing on conditions like Raynaud's and scleroderma in the feet, because there aren't any qualitative reviews on that. So we might be able to feed into some information into this group afterwards.
Use some of this material.
Yeah.
I would say I would be disturbed. I'm sure it's true, but if you're a physician who takes care of patients with scleroderma and you're not looking at their feet off without socks and shoes every time you see the patient, you're not doing the right thing.
Can I interject here? As Susanna Proudman, I'm going to be talking shortly about the Delphi surveys that we undertook. We did discuss the issue of including digits on the feet at one of our meetings, and the actual help text, which explained some of the potential target domains that were included in the Delphi's, related to pain or numbness or tingling, etc., of digits in hands or feet, directly attributable to Raynaud's phenomenon. So we did make the leap to include the feet in the Delphi. We, on the other hand, don't have that qualitative focus that Heidi mentioned to really understand whether the experience is different in the feet compared with the hands, and is obviously still worth pursuing.
Dr. McAlee?
Hi, great work. Thank you. So I'm from the States, Baltimore, Johns Hopkins. Question is regarding digital ulcers and whether there have been discussions as to whether to focus solely on those that are ischemic in etiology as opposed to mechanical or calcinotic. I guess my concern would be, if you are thinking about clinical trials and interventions, those that are mechanical or calcinotic in etiology might not respond the same as those deemed ischemic in nature. And have you guys had discussions on that?
So I'm going to ask Dr. Herrick to maybe tackle that, because this is something that comes up. It's a good question. Ariane, do you want to address that?
Yes, thanks very much. Well, this is a subject close to my heart because most of the clinical trials have confined themselves to ulcers which are at the PIP joint or distal to the PIP joint and often on the volar surface of the hand. And, the so-called ischemic ulcers, although we know that all digital ulcers are ischemic, it's not just the ones in the fingertips. So you raise a very good point. And I think extensive ulcers, and certainly we know that ulcers over calcinotic lesions do take longer to heal, and they're often very refractory to treatment. And so, of course, that's why they tend to be omitted from clinical trials. But, I think it is something we need to address because there's a huge burden out there due to extensor aspect ulcers and due to calcinotic ulcers. So we do need to try and find ways of capturing these in clinical trials. That's my opinion anyway.
I will add that, and Ariane's done some of this work as well. In trials of digital ulcers, we've done research, not we, but others have done it where we've even sent pictures out and various things. And there's disagreement even among so-called experts about what's an ulcer, what's not. It's a difficult study. Real life experience. I'm here in Omeract, unfortunately, a patient of mine, recent onset, diffuse scleroderma, has what we thought was an ulcer, couldn't really tell just by the pictures. So she came in today and was seen by NP and Dr. Sandorfi for me. And it's not an ulcer, it's an abrasion where the things are, but it's very hard to tell those differences until you've seen a lot of them. And so it's actually not a trivial factor in clinical trials as well as clinical practice. Other comments or questions, Lisa?
Yeah, so I congratulate everybody on the scope of work, especially those scoping reviews. My goodness, it was a ton of work. And I appreciate you trying to incorporate patients who are not primarily white or light skin. I noticed that I think that most of your populations were primarily, all of them were primarily English speaking. I did see the 17 patients in Leslie Sakaku's cohort from New Orleans, and I appreciate that. Curious to know, right? Well, so the difference of skin tone is important, but so is language. And I'm just curious as to whether there's any prior data known as to whether a patient's experience might be different and would have answered the questions differently if they were not a primarily English speaking person, and if you think there's any chance that that might impact PROs in that way.
Well, I'll just say that's a good prelude to the Delphi, where we worked hard to go to other countries and other ethnic groups, geographic groups, to try to get more input beyond. A lot of the work has been done in the US and the UK, but there's a lot of the rest of the world that represents about 5.2% of the population of the world. So it's a good point. I'm not sure the language issue, how they might describe it differently. The experiences question is, are there other physiologic and cultural differences that impact?
The reason I say it once, I recall years ago with this, I can't remember which focus group, it might have been arthritis. There was one of the arthritis focus groups in which the word stiffness.
Oh, no, the language issue is a big issue for sure.
Okay, I thought you were saying it. That's why I'm thinking of like words.
I think we'll see a little bit about this in the Delphi. We tried hard to go across. Other questions about the work we've presented so far? Okay, let's go on to Dr. Proudman and the Delphi exercise. And I would just say that this was completely and totally informed by all the things you've heard already, which is the scoping reviews, the qualitative research, the experience of the investigators, and the experience of the patients in our group. Susanna. Susanna Proudman, are you there? Are you on?
You're on mute, Susanna.
Thanks, Peter. If we could move to the next slide, please.
Okay.
So as we were aiming to identify candidate domains to develop separate core sets of domains for Raynaud's phenomenon and digital ulcers, we undertook 2 Delphi exercises with the aim to prioritise the candidate domains identified from the scoping reviews and the qualitative work that had already been undertaken. Please, on to the next slide. So we endeavoured to follow OMRACT principles for these Delphi surveys, to reach consensus among multiple stakeholders, aiming for at least 30 people from each stakeholder group and for multiple continents to be represented. As a reminder, ideally at least 70% agreement in all groups is required for a domain to be included in the draft core set. Next slide. The patient research partners were required to be people with systemic sclerosis with lived experience of Raynaud's phenomenon and or digital ulcers for the respective surveys. Other stakeholders were adults who had treated patients with Raynaud's phenomenon or digital ulcers. The PRPs were recruited through international patient support groups and other stakeholders through a range of international scleroderma research groups. If you could advance, please, Peter. We aimed for a minimum of 50 in each group and the surveys were in English. Next slide. The candidate target domains included in the survey were categorised according to the OMRACT core domains. For Raynaud's phenomenon on this slide, the pathophysiological manifestations included a range of symptoms of Raynaud's phenomenon attacks and patient global assessment. Life impact included domains related to function. The domain termed adaptation to managing life with Raynaud's phenomenon, as we've heard described by John earlier, and health-related quality of life related to Raynaud's phenomenon. A single domain related to resource use was the need for hospitalisation due to Raynaud's phenomenon, with subsequent responses to the survey indicating that this hospitalisation is likely to be due to complications of Raynaud's phenomenon, such as critical digital ischemia, as Ariane mentioned in her presentation, rather than just the symptoms of Raynaud's phenomenon itself. Biomarker domains were assessment of changes in perfusion and temperature assessment due to Raynaud's phenomenon and serum biomarkers. A glossary of domain definitions and images was prepared as a resource for respondents to both surveys. Next slide. For digital ulcers, the pathophysiological manifestations included symptoms of digital ulcers and both physician and patient global assessment. Life impact included domains related to function, adaptation to managing life with digital ulcers, and health-related quality of life. Domains related to resource use were complications such as infection and the need for digital amputation due to digital ulcers, need for analgesia, and hospitalisation for digital ulcers. Biomarker domains were assessment of changes in the microvasculature adjacent to DUs and wound biopsy. Next slide. Respondents were asked to score each domain from 1 to 9. Please advance, where 7 to 9 means critical for inclusion in a one-year clinical trial of Raynaud's phenomenon or digital ulcers. And they were also asked to add additional candidate domains if the respondents didn't feel we had covered all the appropriate domains for these two conditions. Next slide. After round 1, 109 PRPs and 180 other stakeholders had commenced the Raynaud's phenomenon survey. Please advance. And 47 PRPs and 136 others had commenced the digital ulcer survey. After round 3, these had fallen to 62 PRPs and 132 others for Raynaud's phenomenon, and 20 PRP and 105 others for digital ulcers. Please advance. Next slide. Overall recruitment of each stakeholder group was satisfactory for both surveys, with respondents from all 6 inhabited continents as displayed. Please advance, although we would have liked a few more patients with personal experience of digital ulcers and from Africa, as there was only 1 person. Next slide. So these are the same potential target domains for Raynaud's phenomenon as displayed earlier, now colour-coded to indicate the scores they received in the Delphi. Green indicates that 70% or more of each stakeholder group scored the item 7 or more, and hence that these should be included in the core set. For pathophysiological manifestations, this included severity of Raynaud's phenomenon and frequency of attacks. And for life impact, a number of items which could be broadly grouped under the target domain of function, as well as adaptation required to manage life with Raynaud's phenomenon and impact on health-related quality of life. Please advance. More than 70% of the PIPs, but not the other stakeholders, voted 7 or more for coldness, which is highlighted in blue. And then in gold, pain, duration of attacks of Raynaud's, patient global assessment, and the need for hospitalisation received a score of 7 or more from 70% or more of other stakeholders, but not from PRPs. Those written in red were discussed by the group and considered for promotion to the core set. Items with the cross-hatched background did not reach 70% or more from either stakeholder group and were not considered further. Measurement of microvascularity in red at the bottom of the slide was one of the additional items suggested by survey respondents, indicating that the original item for assessing the microvasculature, assessment of changes in perfusion and temperature assessment due to Raynaud's phenomenon, wasn't considered sufficiently inclusive as currently phrased. So including this new item was also discussed. Next slide. And the domains for digital ulcers are listed on this slide. In green, 70% or more in each stakeholder group scored the item 7 or more and should be included in the core set. For pathophysiological manifestations, this included symptoms of digital ulcers, healing and physician global assessment. And for life impact, again, a number of items which could be grouped under a single domain of function, as well as adaptation required to manage life with Raynaud's phenomenon and impact on health-related quality of life. All 4 items for resource use were also scored highly by both groups. The working group discussed grouping these under a single domain called hospitalisation or needing urgent intervention for digital ulcers. As highlighted in blue, more than 70% of the PRPs, but not the other stakeholders, voted 7 or more for sensitivity, impact on emotional wellbeing, and assessment of microvasculature adjacent to digital ulcers. In gold, as for Raynaud's phenomenon, patient global assessment received a score or more from 70% or more of other stakeholders, but not PRPs. And again, the few items with the crosshatch background did not reach 70% or more, so were not considered further for inclusion. So I'd now like to open this work for discussion.
Thank you very much for that presentation. I was wondering, there's one concept that really rang true in the qualitative part, and that was the concept of vigilance. And I was wondering how it fell in the Delphi, or did it make it into the Delphi? And how did it fare?
The concept of vigilance, I don't think was actually included in the Delphi. In the end, we discussed that as to whether that really represented adaptation, that in response to the vigilance, patients made modifications to their daily lives to preemptively prevent the experience of Raynaud's phenomenon. So it wasn't included as a separate item in the Delphi. Peter, I don't know if you want to go back to the 2 tables.
I just was playing with microphones. Chris.
Hi, thank you very much. I just had a clarifying question. In the results for Raynaud's, I missed it, I think. The red text indicated what? If you can go back maybe 2 slides.
Yeah.
So where's the red line?
So the words in red, you can see where they landed in terms of the overall responses from the 2 groups. So those that were in the gold boxes were scored as 70% or more by others, mainly clinicians, but not by patients. But the working group discussed whether they were of sufficient merit, and that, you know, I can't remember the exact details, but they were not far off the 70% mark for the PIPs, whether to promote them to the core set. So whilst they may not have reached 70% from PRPs themselves, the discussion with our patient research partners in the working group, our understanding of the qualitative work from John indicated that these may be worth considering as part of the core set. So in this case, pain and the duration of the attacks of Raynaud's phenomenon, and this item called need for hospitalisation due to Raynaud's phenomenon, which covers one of the more serious complications arising from Raynaud's phenomenon, most likely critical digital ischemia.
You know, I think it's good to remember first that the Delphi is informative and advisory to what you're doing, but it's not an absolute. So you can deviate, and we take everything into consideration, such as we know. Furthermore, things that aren't necessarily advanced or get 70% doesn't mean they're not important or interesting. They're still interesting, and they're still something that can be studied. But we're not judging. It's just you have to parse. I also would say it's probably, I'll let these next two people talk, but we can get back to the language issue because we had a lot of discussion about that.
Thank you. I'd like to just come back to the pain and try and separate some of that. Oh, sorry, Mary Cowan, I'm a PRP. I'm quite interested in how maybe people separated pain and the burning tingling, and maybe that's why they weren't coming out as high for patients, possibly.
So I think we were quite surprised that these didn't rate higher, because as clinicians, we have, I guess many have been under the impression that burning and tingling and other sensory changes are, I do significantly overlap with what might be interpreted as pain in a sort of more neuropathic sense. I think as we move on to our draft core set, we still felt that sensory changes in response to cold as part of the Raynaud's experience is actually worth further study. So we've considered adding that to the research agenda, because we appreciate that pain is something of an oversimplification. Yeah. And I guess we, just in response to the earlier question, of the actual pathophysiological manifestations for Raynaud's, the only two that really made it through were severity and frequency of attacks. And severity in itself is a sort of somewhat broad and nebulous concept. The patient global assessment itself didn't make it through. It's interesting that the PRPs themselves don't necessarily score that as highly as you might expect. So we did feel that something of the experience of Raynaud's phenomenon was being missed if we were to adhere just to the results of the Delphi. And to that end, we included pain, but acknowledged that that may not encompass the full or capture the full sensory experience of having Raynaud's phenomenon.
Thank you.
I think John Pauling wants to make a comment.
Yeah, well, I think the qualitative research, it was fascinating, actually, the physical symptoms. What we found was there would be some patients whose Raynaud's attacks are extremely painful, and for them, you know, their top three symptoms of Raynaud's were pain, pain, and pain. So if patients have painful episodes of Raynaud's, it's an extremely important symptom. But there are definitely some patients with scleroderma where pain doesn't seem to be so much of an issue. And I think that's why clinicians and investigators rated pain highly, whereas it didn't actually reach the 70% threshold across all of the patients. And then it does seem that some of the patients then have these other sensory symptoms. So it's not necessarily painful, but they get these hypersensitivity and burning. And this we've exhausted many hours of discussion trying to navigate the best approach and way through in terms of core set and what to include. And so as Susanna said, I think the upshot of those discussions was that we thought we couldn't leave pain out because it's so important when that's a very important symptom, but recognizing it doesn't necessarily or isn't the key symptom for all patients.
Thank you.
Yeah, I would add it's this is why you involve patients in the work, because we thought we knew what patients think, but they will tell us. And I think that was very informative. Additionally, I think if you talk to patients, and I think John's work says that, they're very clear about differentiating tingling and burning from pain. These are different things.
Yeah.
And we could easily lump them together, but it's probably a bad idea. You'll see that
Yeah.
some of this goes into the research agenda because we probably should try to understand it a bit better. Are there other questions, comments? Gulen?
Actually, Peter, can I dive in just on duration of attacks? I think this is where the Delphi exercise has been, and the qualitative research have really given me better insight into Raynaud's, because we've traditionally attached a lot of importance to duration of attacks. There have been a number of clinical trials where that was the primary endpoint. And what we've learned from patients, and perhaps that's why patients don't consider it absolutely vital to be collected, is that patients, when they have an attack of Raynaud's, do not sit back and just wait for it to end and allow it to go on for 30 or 40 minutes. They take positive steps to ameliorate their symptoms. And I think that may be one of the reasons why duration of attacks isn't something that patients consider very important to measure, whereas clinicians traditionally have.
I think it's also because it's something we feel we can measure, but that's not a good reason to measure it. Gulen Hatemi.
I'm really with the patient research partners with the need for hospitalization, because I mean, you don't hospitalize patients for Raynaud's phenomena, and you hospitalize them for digital ulcers, but maybe the domain itself, one of the domains should be developing a digital ulcer for patients with Raynaud's phenomena, instead of need for hospitalizations, which is a very indirect domain, I would say.
There's some controversy about if digital ischemia is actually on the far end of the spectrum of Raynaud's as opposed to digital ulcers, because it's obviously all related. So digital ischemia is the very severe form of vasospasm on top of fixed vascular problems. Digital ulcers may be due to ischemia. So it's a spectrum, and you'll see in the course that what we think about that. So you're right, it is tricky. I would also say what these interplays, and we'll talk about it with the course set, is if you're studying Raynaud's phenomenon, you should certainly study whether or not patients end up developing digital ulcers and other things. And if you're studying digital ulcers, I've not seen a study where you don't also study Raynaud's, at least from a pharmacologic development standpoint.
Can I ask another question about
Yes,
the other
same
part?
price. Yeah.
Yeah, the digital ulcer one. Could you change the slide, the next one? I was wondering if duration of the digital ulcers is a domain, or did I miss it?
Say that again.
Duration of digital ulcers. So there is number of digital ulcers, but not duration of digital ulcers, which I think is very important, especially if you're conducting a trial with topical agents. I mean, if the aim of the trial is to assess whether healing the digital ulcer is an issue, and I think duration of digital ulcers.
So I'll answer that because this came up in a famous trial. So I think healing, they change from active to non-active, then healed. So you could say, if you're studying healing, you could do time to healing, for example. So the domain is healing. So that's a good point. It doesn't really come up. I don't know if others want to say. I will tell you that the differentiation between active digital ulcers and healing is such a big issue that it actually resulted in the fact that a drug, Bosentan, was approved in the EU, but not in the United States for the same data. So it's a big issue. Anyone else in the group want to talk about duration of digital ulcers versus these other things?
So Susanna can correct me, but I think the small print that accompanied the healing domain talked about time to healing, and because I think you're absolutely right, that is important. And certainly when we were considering the term healing for the domain, we were thinking about how long these ulcers took to heal and the duration that they lasted. So I think that is absolutely very important.
That's correct, John.
So Lisa brought up the English speaking and trying to have a more diverse study population. We actually spent, and I let others discuss, we spent a lot of time, Dr. Park smiling, talking about whether to go to, how to go to other countries, whether to do other languages. This is a pretty common OMERACT issue, actually. So this is broader than this group, and we face it in others. Our compromise was we'd go to lots of countries, which I think we did a pretty good job of, but participants had to speak English, which is definitely excluding some people. But sometimes you have to be practical. The ability to translate especially translate these kind of medical terms into both medical and lay person language to get it right was highly problematic. Programming the Delphi manager in 6 different ways, I think, would have caused the generally peaceful Shauna to be a different person, and because she was fantastic in making this work. And we really had struggled with that. We struggled with going to Canada where they didn't want, you couldn't do it unless you also had it in French. So it really is a challenge. I don't know if some of the others on the call want to discuss this from our group, but we felt we made a compromise. We did better than just the US and UK, but it's not perfect. Hunter.
Yeah.
Well, let's get the audience to discuss first.
Hana Adreskinli from Turkey. Inclusion of other ethnicities and countries seems valuable, but in this case, do we really expect much difference between ethnicities? I mean, what we see miles away, thousands of miles away in Turkey as systemic sclerosis related or Raynaud related digital ulcers, I think it's quite similar to yours. I don't think there would be much difference. Of course, if our patients were available.
Yeah, I guess maybe I'll comment as Turkish American. So I think so I'm in the myositis working group, right? So especially for some of the symptoms like pain, I would say that there are cultural differences of reporting the pain. So some may say that, I mean, I can personally say that Turkish patients reported less pain than Americans. Usually, this is my personal observation. Exactly. So I think there are some cultural differences in the perception and reporting symptoms such as pain.
This is Lisa Christopher Stein again. I don't think I introduced myself originally for those on remote. I'm also the co-chair of the myositis group, and I completely understand the compromise. So one comment is just making sure that you mention that you've thought about it methodologically, and sometimes you make a choice. I understand you'll have limited resources for sure. I mean, I think that comes down to the question as to exactly this, whether this is an experience that's lived differently in different populations or not. And it sounds like there's debate about that. I also recognize we all make compromises for the resources we have, and it's better to have an outcome than not, a measurement than not. But I would just make the comment that in your methodology or in your manuscripts to make sure that, because I think a reviewer would ask this, and the fact that you've thought of it so carefully and said, look, we made this compromise, I think that's fair, but should be outlined.
Yeah, I would also say, I don't know if Susanna wants to talk. She's led our Delphi. What we haven't done is analyzed. It's a little hard. Our sample size is really small, but should we sort of say, okay, we'll go English-speaking countries versus non to see if there's much difference. I'm a little concerned that the sample size is so small that it's inaccurate. So I think this goes to the old, perfect, the enemy of good. We would never have gotten it done, but it's broader than it would have been 20 years ago, but so there's progress. Any other comment? Oh, Dorcas and then Gunnar.
Oh, I'm Dorcas Beaton from Canada and Omrat Methods. I'd say also, like, you've done a great job. You've tried to address this issue. You've done as much as you can at this point. So flag it when you get to your instrument selection. Then maybe when you're looking at the sensibility and does this match the concept, might be a time when you could reach out to some other languages. So I think you've done a really good job.
I will just, I'm taking notes. I hope others are. This is an interesting issue because if we think a lot of what will be measured is patient reported, then language, forget the cultural differences, just the language differences are incredibly important. So when you create these instruments, these are not simple concepts. I don't think simple is the wrong word. They're not, precision is important, tingling versus pain versus this versus that. So you have to sort of do the language issue as well for the instruments. Gunnar Thomason.
Yes, hi, I'm Gunnar. I see on the Delphi for the digital ulcers that one of the very few items that the patient don't like is the patient global. And I just wonder why why is that? I am a physician and I hate the physician global. Maybe that is something, but there it is often used, but there is just something about it that was curious why patients don't like that.
You want to say anything?
I think maybe there's a misunderstanding amongst patient group of what is meant by patient global.
So I'll tell you that in a separate group I'm part of, we actually have a paper. I don't know if it's out yet. It's hard to keep track, but I think that looked at the idea of globals in scleroderma, really. And we'll see in our vasculitis, we're actually relying on globals, but the need for defining what the global is about is crucial. And if you go from study to study, they're often worded differently, both physician global and patient global. And it's actually a problem. It's a big problem. And so the concept is great because when you're in the office, you do try to take a global assessment. And the first thing you might say to a patient, is, how are you doing? How's your Raynaud's? And they're going to give a global response. So it is hard, but I think the variation is high. And so as we move it forward, we need to define them well. I think it's a good point. John Pauling.
Well, so I think on the patient global, one of the experiences we've noted in the qualitative work is, and in fact, with the Raynaud's study, there was a sub-study where we actually gave patients some of the instruments that we typically use, including a patient global assessment, and then asked what their perceptions were. One of the comments we got back was, if you have 10 mild Raynaud's attacks in a day, how does that compare to a day where you have only a single attack, but that attack is extremely bad? And how do you then score? So I wonder whether some of those difficulties patients have in attaching a score to a very broad-ranging life experience and how that score may differ depending on different days, I think is one of the issues. And for digital ulcers, that the parallel there is, if you have 3 digital ulcers, but they're on your thumb and forefinger, that will have a much bigger impact than having 1 ulceration on your little finger. So I think patients sometimes struggle with those. Just on the last point around language, we were very careful when we named our domains to make sure there was no ambiguity in terms of what we were trying to capture. We did find when we did the qualitative research, some of the English patients say, Raynaud's drives me mad, whereas that term didn't chime with a lot of Americans who said, well, no, it doesn't make me go crazy. So there was another one, another example where the same word had 2 slightly different meanings in terms of cultural context. But when we used our domains, we made sure that we were quite clear as to what we were trying to capture of those. Another interesting one that came up in the Raynaud's was feeling blue, which we avoided using that term for obvious reasons.
So once again, two countries separated by a common language. But so I'm going to move us on because we now come to our draft course set, the moment you've all been waiting for. And so I'm going to, Susanna, do you want to make a final comment?
I'll keep it quick. Just to say that the definition that was provided for the respondents was a patient global assessment was patient assessment of all the ways in which digital ulcers impacts on a patient's health and well-being.
Okay. So I'm going to go on. And so as you, those of you who have been OMRAC for a while, we know that we have the onion, but some of us have actually sometimes deviated from that particular product, that particular food group. And for VEJETs, we created a circle of things. And so the question is, can you graphically display things differently? So we had a little discussion about that. So I'm going to show you what our draft course set looks like. And I'm going to start with Raynaud's. And I want to just remind you that we combined the data and insights from each of the following to get to our course set, which was the scoping reviews, the qualitative research, the Delphi, expert opinion of the working group, including our experts, our patients. And so I think it's not one formula to get there, and you have to sort of massage it to make it somewhat practical and make sense. And so here's where we're at now. And this is the pyramid. And this is for, oh, look, I'm being called, but I shall ignore that.
Put it in the onion, that's fun. Yeah.
So this is how we view it with mandatory on top, since it's more important, optional, important domains and research agenda. And you can see it's pretty, there's a lot. We have a fair number of items within the different categories. We kept the categories. I'm not sure if we should when we actually present this, but I think it actually makes sense. And so we've included pain due to Raynaud's, severity of attacks of Raynaud's, duration of attacks of Raynaud's, and the frequency of attacks. And then under life impact, the impact on function, quality of life, health-related quality of life, and daily life and adaptation. To what extent those are all different. We actually discussed that this morning. We could combine, we're not so sure we should. Under research utilization, it did come up the hospitalization or urgent intervention. And I think your point was a good one, Glenn. And death, of course, is in all, we don't really die from Raynaud's, we hope, unless you get a tremendous ischemia and infection things, but that you don't. But it's in all core sets. We then have optional important domains. So this is where coldness comes back in, because it was a lot in the qualitative research. It's interesting. We're not really sure how to define it and how to measure it. So it's an area but the people are doing it. And the patient global assessment is there. Didn't quite make it to mandatory because there were, it wasn't that endorsed. And then the research agenda are the biomarkers, measurements of microvascularity, and actually Dr. Herrick's done a lot of work in that area as well. Impact of emotional well-being, assessment of changes in perfusion and temperature, which is somewhat different from measurement of microvascularity, or there may be some overlap there, and sensory changes, the burning, the tingling, the numbness. Again, they come up a lot, but how do you measure it? So this is what we think of as the core set for Raynaud's. And I think I'll show you the DU1, and then we'll come back and discuss. The DU1 is similar, but not exactly the same. Again, the mandatory domains, the optional important domains, and the research agenda. And the so for pathophysiologic measures, it's the pain, the number of digital ulcers, the healing, the global burden, and then the physician global assessment. The patient global assessment made it to important, but not mandatory. Life impact, again, very similar impact of DUs on function, quality of life, daily life, and the hospitalization piece came in. And these have been more relevant, I think, for DUs and death. For optional important domains was the concept of sensitivity in the patient global. And again, serum biomarkers and measurements of vascularity and emotional well-being. When you look at them across, we actually had a long discussion. At first, we were going to have one core set diagram, sort of a Venn diagram, where things that were the same, and then things that were separate on the sides, which we did actually for another group, large vessel vasculitis. But we really felt these were separate entities and they deserved their own, and there was enough differences. However, as we were putting this together, and I got this together even this week, these are the items that are the same in both, which is interesting. So there's a lot that is the same, but there's also enough that's not the same. And so we felt that they should stay separate, but I think it's a good use of this conversation. So maybe I'll leave it on this one, or should I go back to Raynaud's? I'm interested in people's comments and about any part of the core set. And
awesome. Thanks so much. This looks great. I two comments or questions. One regarding the digital ulcer pyramid. I'm having, I guess, a question regarding the distinction between the physician global and the global burden of digital ulcers. I'm not sure if someone can kind of elaborate on that and explain more. And then the second one is, practically, how do you envision using these two pyramids in a clinical trial? So I'm envisioning like a Raynaud's clinical trial. Would there be a conditional so that if a patient develops a digital ulcer, then that pyramid would be activated, so to speak?
Okay, I'll actually take the second question first, since I don't know the answer to the first one. I'll let someone else do it. So in a clinical trial, I would remind you that a clinical trial, you can measure all sorts of things that are not in the core set. You can, if your core set is all about, if your clinical trial is to measure a particular biomarker and it's in the research agenda, that's fine to go ahead, except you should still measure everything in the mandatory domains. That's the idea. But I would say there may well be just a clinical trial of just Raynaud's phenomenon. I don't think if you're concentrating on getting 300 patients with Raynaud's phenomenon, you may record digital ulcers, but you're not measuring it for approval of the drug. You're not measuring it as the primary outcome. So you would do the mandatory domains for Raynaud's, and you would have some other way to measure digital ulcers as an adverse outcome or a disease outcome, but not have to do all of that. Similarly, if you're doing a study of digital ulcers, you will focus on a very distinct subset of patients with Raynaud's who have digital ulcers, and you will do the mandatory domains there. You may want to measure Raynaud's. It may depend on the nature of your intervention, the drug, et cetera. If you're doing a topical or surgical approach to, I don't think you need to measure the Raynaud's. If you're doing a drug that changes the vascularity, you probably want to measure both. So I don't know if that helps. So I think that's one of the reasons we separated them. I don't know if anyone else in the group wants to comment on that before we get to your first difficult question. Okay. So the first question was about the global burden versus physician global assessment. Anyone want to comment on that? It's a good question.
I'm happy to jump in. As far as the definition used in the Delphi, global burden of digital ulcers was described as the global burden and impact of digital ulcers. This may be related to number, size, or location of ulcers, as well as time to healing. And so it is a little bit problematic, this concept. It's certainly an item which was rated highly by all stakeholders, or both stakeholder groups. It's a little bit like severity of Raynaud's phenomenon. And I think this is a problem we face in many of the diseases in trying to define outcome measures that reflect sort of overall severity, and that there are issues with terminology in relation to burden versus global assessment versus severity. And you could argue that maybe some of these could be collapsed a little bit further, but with more detailed definitions as to what they actually encompass, because we were also a little bit concerned about the sheer number of domains that remain in the mandatory domains. And we've not wanted to veer too far away from what items were actually included in the Delphi, what potential domains were actually included in the Delphi, so that we are reflecting what respondents were actually scoring. But maybe there's a sort of a next step of collapsing some of these pathophysiological manifestations in particular. But largely, I think that probably requires further research to try and tease out whether they are actually different things, or whether there's such significant overlap that they could be incorporated into a smaller number of domains.
Yeah, I think as a domain, so the global burden, my understanding is that it's a patient-reported life impact measure, but the physician global is, again, physician-reported, and it's only assessing the patient on on the day of the assessment. Again, it's physician-reported global. But the global burden, I think, again, is a patient-reported an impact of digital ulcers on the life impact.
I think this also brings up, again, relates to the discussion we had in the workshop this morning, which is the critical importance of defining your domains. And so I think when we publish the course set, I'm taking all these notes, which we'll do separately, I think, from the Delphi, we will really lean on the definitions and what or at least some guidelines for what the definitions should be, because I think that's important. I would also just, for those of you, for some reason, have not done research in Raynaud's phenomenon, why you should have, but if you haven't, the Raynaud's condition score is something we developed some time ago, actually is a diary approach. It's a validated measure that takes into consideration the duration and the frequency and the severity. And so it's all sort of piled into one, and it's reported as a global measure, but also the individual elements. So these things do happen. It is a fair number of them. Item reduction is problematic, though, until you have more data. Other comments, Lisa?
I have one last question. Sorry, I stepped out for a moment, but do you imagine that this will be adaptable to other diseases in which Raynaud's is a prominent feature, or is it only scleroderma?
So, so the last thing yesterday, we have a graphics person that's helping create these, is I want to make sure that when we really do it, it will say Raynaud's phenomenon, systemic sclerosis associated Raynaud's phenomenon, because we really only looked at it for this group. And I think my sense is primary Raynaud's, where lots of people, especially young women, develop it early, they have it. It's a different process. The Raynaud's phenomenon in myositis or lupus is more like this, but it's not as generally burdensome as in scleroderma. What do you think? I mean, I think if you were going to study this in myositis, I think this would help you.
Yeah, I think that's exactly what I was going to say. I think you're right. And John and I have actually, written and talked about this a lot. So yes, I think the short answer is yes, it's often not burdensome until it is. It tends to be most burdensome in those with overlap with scleroderma features.
Then I think if you have scleroderma / myositis, you can use everybody's course set, and it's a 3-hour study visit. What do people think about separate versus the same? I think our concept is they're separate, but published together and show them like this almost. I could see this as being. Dorcas, did you have a comment?
Yeah, the first comment is to your graphic designer. Maybe you may prefer to put them upside down so that they're pyramids instead of Merkel's carrots.
So, well, it's the Peters pyramid, or is it somebody else's other thing? But I think that, so actually I had them the other way, and there were members of the group who wanted it like this. So being the consensus kind of person I am, we flipped it.
Okay, so the
onions are unattractive.
So the series.
These days, with so many different things, I think the problem is the extra. I view personally the concentric circle idea and the going out. It almost emphasizes the outer circles more when it really the core is more. I think that's really our feeling. But also we want to have a little fun with it. We are not done. We could do lots of things. What do you think we should do? We're thinking 3D. We might get Chat GPT to give us some ideas on the course set.
So the serious one now. Did you consider adding new manifestations, especially considering that the same drugs are being used for pulmonary hypertension? I think it would be useful to collect data on that, new manifestations as a domain. So
let's see what other people in our group think. New manifestations of scleroderma or new manifestations
of scleroderma.
Well, this is not about scleroderma. This is about a subset. So I think
but I mean, this was developed in the context of systemic sclerosis, right?
So again, if you're doing a study, a trial of Raynaud's phenomenon in scleroderma, you should use these mandatory course sets to measure the Raynaud's part. If you choose to also measure other aspects of scleroderma, which is you can then use other measures. But I wouldn't put it in the Raynaud. I don't think a study of Raynaud's requires you to do a skin score.
Yeah, but I mean, whenever I'm reading a digital ulcer study, I always wonder if they mention something about the pulmonary hypertension.
Yeah, it would be.
If you're doing a 1-year study, which I think is the purpose here, during 1 year, all patients would have at least one echocardiogram, one measurement of the pulmonary artery pressure.
We have a state, there are core measures for pulmonary hypertension you can add if you want. It's a very different trial to try to capture both. It's not necessary.
Yeah, no, I think I'd agree with that. I think, and we've discussed this within the group, the choice of the endpoints and your endpoint model for any clinical trial will very much depend on the design of the clinical trial. So you could potentially do a very short-term trial of Raynaud's phenomenon or a study of digital ulcer healing, where you certainly wouldn't expect patients to develop new pulmonary arterial hypertension in the midst of that short period. I agree with you, though. I think you would certainly want to capture within your patient demographics what proportion of the patient cohorts had pulmonary hypertension. I think more often than not, you'd probably find that patients with PH might end up being excluded from clinical trials of both of these manifestations because of their background vasodilator therapy, although that shouldn't necessarily be assumed.
Dr. Meckley, another comment. Great.
Thank you. I just want to add on that I think the resource use boxes are very important. And this comment has already been made, I guess, to some degree, but the definition is going to be really important here. I'm just thinking of our own practice of, what do we mean by urgent intervention? That could be obviously a lot of different things. A visit to the ER, urgent visit in the outpatient, a prescription for oxycodone, and a telephone encounter. So that can go a lot of different ways. And I'm sure you guys will be thoughtful about it, but.
We hope to be. I don't think a visit to an ER is an intervention. I think if they get a medication in the ER, it's an intervention, unless they put them in a very that's medication use. That's a different thing in a trial. That's actually from a trial design analysis standpoint, concomitant medication use is incredibly important, but also incredibly difficult to capture how it influences your outcomes. Other comments from other people? It is important to define these things. But I mean, I think the idea is if you have digital ulcers and you have an intervention and 20% of your patients end up having to go into the hospital and 20% have great healing, I don't care. I don't want 20% of people going to the hospital. That's not a good outcome.
Maybe not the aim of this work, but if a company is wanting to make a clinical trial, what would you suggest them as the primary outcome among these?
That's a very good question. Who wants to answer that very good question? Dr. Herrick, you should answer that question.
Okay, well, thanks, Pierre. I think it depends for Raynaud's or whether it's a Raynaud's study or a digital ulcer study primarily. And we've had a lot of discussion about this. And I know that Peter and John have also put a lot of thought into this. I think if I can take digital ulcers first, I think number of digital ulcers is probably going to be a major primary endpoint, but with all the nuances, as Peter referred to earlier, about what is and what is not a digital ulcer. So it is complex, but and people have tried to get through this in different ways. But I think it's always going to be the number of new ulcers, I would have thought, in a longer study of digital ulceration. For Raynaud's, I think it's difficult. I think it depends whether it's a phase 2A or later phase 2 or a phase 3 study. And so I think that's very dependent. So that's my take on it. I think for early phase study, then I think vascular physiological endpoints are important, but we probably don't want to discuss that just now. We're not talking about it.
I think we need to wrap, but I think it's a good, so I'll just tell you there's a parallel project going on that I'm directing with Dinesh Khanna that several of the people in our group are a part of, which is to develop a white paper. We've actually specifically looking at instruments and what instruments are ready for use in clinical trials that would be actually approvable by the FDA. And that's really the key issue that I think, don't talk about anywhere near enough at OMERAC, which is it's all well and good to measure things, but if you can't get drugs into people, that doesn't help you, doesn't help your patients. And so that's a very good point of what your primary outcome is. That has to do with instruments more so than the domains. And it will also depend on the nature of the drug. What is its mechanism of action? What are your intended, what do you intend it to be, the intervention? So it's a good but complex question that goes forward. But the same people, Dr. Herrick's running one of our task forces, Dr. Pauling's running one of our task forces. So it's a timely question. I'm going to end us because I think we're supposed to. I want to thank, I get to stand up here, but I work with this really terrific group. Edith and Virginia, our patient partners, Dr. Park, who is here and supporting us, and everyone you heard speak. It's been a great group. We've really done nice work moving it forward. And I want to thank all of you because this is great feedback. I took notes. All your notes are going to be in the paper. And I'm around, Edith and Hay and I are around all week. So please give us your comments it's still draft mode. It's still draft until we go further, but we'll have to vote on it. So thanks to everybody online. Thanks to everybody here. And thanks for coming. And thank you. And you'll go out and get a snack and come back for the vasculitis SIG, which is in this room and is as exciting as this one. All right. Thank you.